objections, I'm pushing the record button now. This is a meeting that we called just to communicate, not because we have any major announcements or new information, but we want to make sure that any questions that are existing are addressed. I have asked Dr. Scott Crafton, who is the Campus Mitigation Program Manager as part of the UCSB COVID-19 response team, to be here. He is Professor of Psychology and Brain Sciences at UCSB and a great resource. And so I'm, first of all, thanking him for graciously taking the time to be here. And I'm hoping that he will be able to answer most of the questions that will come up. And so before we do that, I'd like most of the time to spend on answering questions or asking Dr. Grafton actually to do most of that, depending on what comes up. But before we do that, let me just give a very brief introduction with an overview of how we got here, what we know. I don't know much, but I'll tell you the little that I do know. In the past 2 weeks, we've had 4 cases of positive COVID tests within the department. There's been one about a month before that. That was a faculty member who tested positive after a trip that involved air travel. He quarantined, and that's all taken care of. But in the past 2 weeks, I may be off by a day or so on what I know, because when I hear about a case, that may not be the exact same day as when the test took place. But as far as I can determine, Thursday, 2 weeks ago, there were 2 cases in 2 different groups that appear to be completely coincidental and not connected. The following Tuesday, there was another case in yet another group. And the following Thursday, almost a week ago now, there was one more case in yet another group. So 4 different groups. 2 of those people involved were close outside of chemistry, but there is no indication of any spread within chemistry. The COVID task force contacted everyone that these people had been in close contact with and followed up. And again, as far as I know, none of them tested positive. And so the good news seems to be that we don't have any, at least so far, any indication of a spread within chemistry. The bad news, of course, is that everyone was vaccinated, which is good news, but the bad news is that it shows what we already probably know by now, is that you can get infected when you are fully vaccinated. There's a less of a chance, as I understand it. It'll be less severe, as I understand it. But there is that probability that's non-zero, and also the probability to then spread it again. Again, less probability, but non-zero. And so this is what prompted us to respond with requesting that everyone wear masks. The building committee got together in the past weekend. That is a committee that every building on campus now has. This was instituted early on in the pandemic, and these committees are tasked with setting out and managing the procedures during the COVID. And we decided that it would be prudent to not just request, but actually require that everyone wear masks. We were ahead of the curve by a day or so, because as you probably know, the campus is now mandating the wearing of masks inside, indoors for everyone, including when you're fully vaccinated. And the Santa Barbara County is now requiring the same thing. So if you're in your office alone, like I am now, you don't have to wear a mask. But if somebody comes in, I put on my mask, which I've ready to do right away when somebody comes in. The reasoning was that we are not in a bubble. We're not alone. If we were all vaccinated and not in touch with anyone else, then things would be very rosy. But we're in a community, and the count of cases in the community is going up. And so, as we experienced, people can bring COVID in that way. More importantly, maybe, we're in a community and we're in contact with people that we can then transfer this to. In my group, I have a student who has someone close to him who is in chemotherapy, battling cancer, completely immunocompromised. I have another student who is a mother with a 1-year-old at home. I can go on like that. I'm in touch with my grandchildren who are 5 years old. We're all having different circumstances, but we're in contact with people who are not vaccinated. And so the best we figured we can do is within our community of chemistry and biochemistry, at least do what we can to mitigate possible spread. And so that's what prompted us to be careful. Like I said, we've been, in the meantime, become obsolete in this policy because it's now universal. We also looked at the issue of people coming back after having been in contact with people with COVID, because there's confusion about that. And maybe Dr. Grafton can help clear that up a little bit. People were told that they could come back right away if they're fully vaccinated and had no symptoms. We thought that was a little strange. The survey, of course, had a question on there. Have you been in contact with people that had COVID for the last 10 days and then didn't give you a badge for 10 days? And so we recommended that people be at least tested negative before they come back. And I still think that that is a sensible policy to follow. But maybe there will be more clarification about that going forward. And we also recommend a lot of or frequent testing. One of the people who tested positive told me that he had a sore throat, as did everyone in the group. And everyone tested negative. And then he tested positive. And so that was sort of a cautionary tale that testing is still important, even with mild symptoms. So those were our recommendations. This is the picture that we're in. My main goal is to make sure that we take care of each other together as a community. And I want to communicate as much as we can, which is why we have this meeting, and I will continue to send out emails. We will use our COVID landing page on our website for information going forward, so that I don't need to bombard you with emails as much. With that, I don't know, Dr. Grafton, if you want to introduce some things before we go to questions.
Sure, I could, maybe I can just give a little context, address the quarantining point you have, because that's a really hot one right now, and then take some questions. Yes, just to give this context, 3 weeks ago, we really started noticing a bump up in cases nationally as well as regionally. And we had good data even by then showing that at least 75% of those cases were associated with the Delta variant. We had all this other additional evidence that the Delta variant, your PCR counts are about 1,000-fold higher than the original Wuhan. So there's more than enough evidence showing it's, you know, highly transmissible. And so we presented that to the chancellor 3 weeks ago, part of his COVID team. And well, just being Cheadle Hall, everything takes longer. And we essentially had a mask mandate memo written 2 weeks ago, but there was a lot of concern back then because we were essentially ahead of just as you were ahead of the curve, we were ahead of the curve. And I think there was reluctance to do things that weren't being advised by the CDC, California Public Health, or County Public Health. And then Irvine, they required a mask mandate. UC San Diego, I think they followed in turn. And then we finally got enough evidence and consensus, I think, by this week to go ahead as well. So we're all thinking alike here that this is a pretty concerning change in the context of everyone being vaccinated and having all these breakthrough cases. So maybe I have a couple slides that are just, I think, always good to sort of, I don't know if you can enable me.
I'm working on it.
I'll just to give everybody likes data. Giving a little context might help. So you're all familiar with this classic New York Times plot from March 2020 of the Wuhan variant showing, you know, the infectivity on the x-axis and fatality on the y-axis with a wide range of fatality because of the age effect. Delta is no different, but in terms of fatality rates so far, but it's way up there, somewhere between smallpox and chickenpox and infectivity. Just because the PCR counts are 1,000-fold higher doesn't mean it's 1,000-fold more transmissible. There's a lot of argument going on in the papers now over what the true underlying R naught is. It's probably somewhere between 5 and 7. That's not 1,000-fold higher, but it is more than enough to create a real problem for us. 3 weeks ago, it was completely unclear, right, whether this could be transmitted from a vaccinated person to another vaccinated person. Everyone was staring at the plots, trying to figure this out in the context of the spreading of cases in California. And here's what's going on in California right now. You can see a clear bump in cases. Overall, we're up to more than 20 cases per 100,000, which is a lot. That's well up in the purple zone, in the old purple tier, if you remember that. Well, interestingly, though, the number of deaths has not bumped at all. And I think this is primarily because of vaccine protection for those who are vaccinated, as well as the fact that the primary group that's getting infected now is a younger age group. And so younger people are less likely to die, regardless of their vaccination status. So that kind of helps explain that difference there. This little downtick is just a missing data effect. Don't worry about that. The CDC keeps giving all kinds of confusing messages, making it very hard to set sort of global policy for the campus. How dangerous is the Delta virus? They'll say, well, it's not dangerous at all. And then, you know, your best friend has been vaccinated will get it and say, wait a second. Problem is, we really don't know the denominator well enough to know what the incidence is of new cases for vaccinated people. And it's spreading, right? This is a dynamic growth problem. And so we're just getting a window into a trend. There's 165 million people who are vaccinated. There's been 66,000 breakthrough cases, roughly, probably more by now. Of those, just over 6,000 have been hospitalized, and there's been 1,200 deaths, primarily in people over 65. So if you look at if you treat the denominator as 165 million, your risk of this is extreme, of getting a breakthrough case is extremely low, but things are changing. We don't really, that's not a fair denominator, because you have to consider what the prevalence is in the community. What's going on with hospitalizations? The other way you can get a window into this is to really look carefully at who's being hospitalized. So this is California data. This is, again, 14-day averages. On the left is hospitalizations. On the right is ICU. So the sicker hospitalized patients, and basically 1 in 4 people who get hospitalized end up in the ICU. And the curves are essentially superimposable. But the critical thing is you've got the uptick that we're seeing, but 95% of these hospitalizations are in unvaccinated people, and they're predominantly 25 to 40 years old. So again, it's hitting young, unvaccinated people predominantly. That's driving what you see in most of the community right now. So that, and then the other question that keeps coming up is this, is it worse for children? Because a lot of people have kids and they're worried that they've been vaccinated, their kids haven't. Is there something now that's different for their kids? This is COVID-net data. This is hospitalizations for children, not infections, but hospitalizations of kids. The little left up panel is all age groups, and you can see the 4 seasonal bumps we've had in overall cases, hospitalizations through the course of the pandemic. The 2 little lines at the bottom are children. If we just zoom in on the children, that's the larger plot. You can see there's a little bit of an uptick on 0 to 4-year-olds in the last month, but it's really down in terms of hospitalizations, but it's in the noise of the time series, right? it's a little hard to make a strong claim that there's been a big jump in hospitalizations in children. So anyone who says that there's more kids being hospitalized now than there have been in the past, there just isn't clear data to support that claim. That's not to say kids aren't going to get infected. It's to say that the risk of hospitalization hasn't changed as far as we can tell. So that's important from a policy standpoint and what we might do. If we look at Santa Barbara, how bad are things in Santa Barbara right now? This is May, June, and July. The upper plot is unvaccinated people. The lower plot is vaccinated people. And it was this steady rise in early July that really kind of triggered our motivation to get this mask mandate going. It wasn't just the cases in the chemistry department, it was the overall effects going on in the community. So we're clear again, and again, 70% of these were Delta variants. Just a few more comments and then I'll open it up. The other thing that really, I think, changed a lot of people's mind was the P-Town outbreak after 4th of July. So this is Provincetown, thousands of people come in there for a party for a couple of weeks. It's a very vigilant community. There was 70% had fully vaccinated coverage. 74, they had 469 cases. 3/4 of them were fully vaccinated. So big breakthrough. And there was just too many people getting a breakthrough case to say that it was only because unvaccinated people were infecting vaccinated people. There had to have been vaccinated to vaccinated transmission. So that really changed everybody's thinking as well in terms of risk and sort of the challenge we face. The good news is there were only 5 hospitalizations out of 469 cases. 4 out of 5 of those were vaccinated people. There were no deaths. 3 out of the 5 had underlying medical conditions. So, and the other thing was the PCR counts and the samples they took were similar whether you were vaccinated or not for the infected people. So that again is good indirect evidence that, yeah, if you've been vaccinated and get it, you can transmit it. And so again, that kind of drove thinking. And then if we just look inside of Santa Barbara County, we had this long dry spell in May, June of no cases, and now we got these bump ups of daily cases. Some of these are the chemistry students. So that's kind of where we're at. You know, if you think about what can we do, right? I mean, this is a really hard problem for all of us. Masking is an easy thing to do. We're all, I think, comfortable with that conceptually, not necessarily physically. You know, we've been doing it a long time. We can go back to that without really impinging on our ability to do work. Distancing, you know, we could distance, but the fact of the matter is if you're wearing a mask, the added benefit of distancing for something that's highly aerosolized and transmittable is not going to be that great indoors. So, you know, we could do distancing, but I think I very much doubt it would add much safety to everyone. We are going to continue to do testing and contact tracing. This is a little worrisome as we move into the fall, because if we really get an explosion of cases from the Delta virus, there's a tipping point where you transcend the utility of contact tracing. And we're already discussing what would that be. We really shrunk the contact tracing team back in May when we were having 0 cases. And so now we're a little bit behind the curve in terms of spooling that up again, so that, they answer the phones, they chase down the cases and so forth. I'm not on that team, but they're a little challenged right now in trying to get ahead of the growth curve we're facing now. And then the last option we have, is shutdowns. And I don't think there's no discussion of moving back to online teaching in the fall. I don't think anybody wants to minimize lab access. No one wants to go to regional stay-at-home orders. And the fact of the matter is most of the transmission is actually occurring at home and in residences, not on campus. So stay at home is not necessarily going to modify the overall case counts. And the last thing is, if we're all vaccinated and the chance of going to hospital from catching a breakthrough case is remote, you're looking at a disease, in my view, you're looking at a disease that becomes more and more like chickenpox, RSV, or influenza. And we don't shut down society for these other viruses. So I think there's going to be more and more discussion about what kind of strategies to are really reasonable at this point. So that's kind of where we're at. And it's always a moving target. I mean, everything's changed in 2 weeks, and it'll change again in another 2 weeks.
Great. Thank you. That's a very illuminating summary. Let's just do questions.
I have one, if that's all right.
Okay.
In MCDB, we have undergraduate who was exposed to someone who's positive, then he tested negative, but it was only a day later. And when can we let him back in to the lab? And should he be tested every other day, or what's the best approach?
So this is the quarantine question, and this is being hotly, we are absolutely split on this right now, because if there's an explosion of cases, let me rephrase that. There are people who have argued that with the Delta variant, if you have a roommate, let's say, who has this, and they're unmasked, and you're unmasked, and you're vaccinated, your exposure time to get a significant inoculation is about 1 second if you're in the same room, right? So that means the whole rationale for this quarantining was close contact. And in the Wuhan variant, that was like 15 minutes with somebody. That was sort of an ad hoc number. Now we're talking about 1 second, right? So that means I walk by you in the hallway. Now I have to quarantine, or now I have to quarantine for 3 to 5 days and get tested, right? Or 10 days, in some criteria. So that means everybody is getting quarantined. So there's a very tricky calculus here of at what point is this just a crazy thing to do? Because everybody's going to have to quarantine everywhere all the time. It just doesn't work, right? If it really is that contagious. So there's some reluctance by some people to continue with the quarantining, because it's just, the other thing is we're talking about quarantining people who are going to get a non-lethal flu-like illness. And we wouldn't quarantine for other flus. So that's the one side of the argument. The other is we should continue on with the kind of quarantine approach we've had in the past, where we do really thorough contact tracing. If you've had any contact with a person who's got COVID, whether you're vaccinated or not, you're going into quarantine until you test, preferably at 3 to 5 days post-exposure. So it's, I don't have that's being argued right now today. So I don't have a definitive update.
So Scott, what are the rules about testing right now?
Well, the rule now would be, they're all changing. I don't know if I have them all memorized. Yeah, if you are exposed, I mean, the common sense things to do is, if you really think you've had a significant exposure, then you should test it you should quarantine and test it 3 to 5 days. The Delta is about a day faster in getting people infected. So before it was 4 to 5 days. I mean, realistic. That's why we're sort of arguing, move it up to 3 to 5 days. It's very, very fast at affecting people in comparison to the old variant.
The testing is done on campus for us then?
Oh yeah. You can the campus testing facilities are still all fully available for everybody. If you've got a net ID, you can get tested. Anybody, and so that's very important for your undergrads as well as any high school students who are working in labs. If they can get a net ID, they can get tested as well.
I was told by someone that the testing can only be done once a week. So if you would want to do it 3 days and then another 2 or 3 days later, that would not be.
That's not true, but I don't know the current schedule. But yeah, the way things are going, it's going to be ramping up. It's the other really interesting thing is for the fall, when we've got 25,000 people coming on a campus, it costs $20 a test. It suddenly gets really expensive to just casually say, well, we're going to test everybody all the time. Those are millions and millions of dollars of testing that has to be considered.
I imagine the fall is a whole different headache.
Yes, there's a UC-wide team that's been tasked to come up with sort of fall planning recommendations that would be applicable to all the UCs. They're basically guidelines and recommendations, not really requirements, and each campus can tweak them to their own local circumstances. And they've been meeting about every other week, and their final version of that just came out, and it's assuming, as the president said, it's going to be in-person teaching in the fall. It's going to be, everybody's going to be expected to wear a mask indoors. It's going to, be uncomfortable for lecturing, but that's just, it's still preferable to online learning, which, as we all know, has had a lot of problems. And then there's just a whole bunch of policies and recommendations around testing students. I think the other thing that's happening right now is, as you know, the president, put out a vaccination mandate for all the students with the usual sort of medical or religious exemptions. We've set everything up so you can apply for those exemptions. The big issue now for the student population is if they don't get vaccinated, what are the consequences? And there's a push. This will probably take a little bit of time to get through Cheadle, but there's a push that basically says if you're not vaccinated by the start of classes, you don't register. We're going to take a real hardline approach and not wait till winter quarter. Just with the Delta, we can't wait for we need at least 95% of the students vaccinated. And if we look at other institutions that have required the mandates, compliance has been actually pretty good. And the number of people who have exempted is actually quite small. It's on the order of 2%. And that's kind of what we're seeing now. We're seeing a trickle of, well, almost no medical exemptions. It's just a trickle of religious exemptions coming in.
Other questions?
I can also say that right now we have data on, I'd say for the fall student bodies, we know that we've confirmed that 75% of them right now are vaccinated. And the other 25% are internationals and out of states, and it takes longer to get their evidence into the system. So it's not that they're not vaccinated, we just don't know that data. So we're in pretty good shape already in terms of fall. There's some chat questions. I should do it that way.
I have another small question. Not all masks are equal. Should we pay attention to that?
Right. I just wrote a memo. I don't know if it's going to go out quickly. With a bunch of, it's like an FAQ almost memo, just all these things that go back to masking. And we're telling people just follow the CDC guidelines, and there's a link to that. And there it's basically two-ply or better. I'll tell you, on campus, the place where this is really a hot issue is the rec cen, where people are using these gator masks because you can go in and out of the rec cen and pull these things up and down real fast. And there too, if they're 2-ply, there's roughly 50% filtration efficiency relative to N95. Single ply is like down in the 30s, so it's not good enough. So,
right.
But we're not asking everybody to wear N95s or KN95s. It just doesn't work. It's not practical. So some of the other thoughts, yeah, the wastewater testing. So UC Davis loves their wastewater testing. And it just so happens they've got the right plumbing for this. So they can do it at a great cost. We actually looked into this at length. Facilities did early on in the pandemic, and it's cheaper for us to just do individual testing than to do wastewater testing, just the way that this campus is set up.
Right, I see you're looking at the chat questions.
Gosh. So the KN95s, N95s, those are the recommendations pre-vaccination. And then in June, we really relaxed things, thinking, oh, we're in great shape with the vaccines. So we can kind of ease up on the N95, KN95 in the labs in the tight spaces. And we eliminated the density requirements. And so that, again, we'll have to rethink all this, just depending on how things grow.
So is the Swiss cheese model a good way to think about this?
Swiss cheese didn't include vaccines.
So I changed the graphic to include vaccines.
Yeah.
The vaccine slide should have smaller holes, I suppose.
Yeah, I would reverse the two on the right. I think distancing is
right.
You're going to get more bang from, just think of aerosol dispersion. You're going to get a lot from just opening a window, right? It's a massive benefit in terms of lowering aerosol concentration. So I would emphasize that over distancing. And the CDC's and California Public Health have also sort of started the same messaging: vaccine, masks, ventilation, and then maybe distancing.
Right, as a general point of information, in our building, we don't have many windows that open, but we do have very good ventilation, it being a chemistry building.
Yeah, you're in good shape. Yeah.
And so we have single pass ventilation in most places.
Yeah, you got HEPA
Good
13. And, yeah,
air replacement, especially in the lab.
ACHs are 8. Yeah, it's fantastic.
Less so in the offices probably, but still.
So I have a question about the offices for staff that are going back and have frequent contact with people. You're saying, so just the mask is okay. We don't need to have any other safety measures in place, like a shield, or a mask is sufficient.
As of today, that's correct. Yeah.
Okay.
It was never clear in the first place. The shields and the face masks really, or the plastic masks, really were a phenomenon of March 2020, when a lot of people were worried about droplet transmission. And we, in hindsight, we know that it's just not true. It's a really small particle aerosol. And so those have far less, effectiveness than just a proper face covering.
Yeah, India, we can talk about this offline. I know the ventilation in your office is not great. And so I was thinking about setting up, coming fall, depending on the situation, setting up something outside to meet students.
Mm-hmm. We do have windows.
Oh, you do? Oh, that's right.
Mm-hmm.
Yeah, and so all those ventilation recommendations we had before, get the windows open, get the doors open, maximize, if you can't do that, get a portable HEPA filter, if it makes sense. Yeah, all those are still in place. But this is a challenge, no one's saying this is easy. This is and I'm not we're all the expert on this. there's many in your department who know a lot more about aerosol than anybody on campus, I think. And, you know, we just, there's at a policy level, there's only so many things we can do. The good news is we're going to do fine, right? You know, we're going to weather this. We might all get sick. We might all end up with the flu for 3 days, and then we're going to be like Iron Man in terms of being immunized. It's going to, I've heard people say, look, why don't we just have all the students come back, let everybody get sick for a week on campus, and then we're done.
Right. So my concern
right.
there is what I was mentioning before, is that we
Yeah.
are in contact with the community, and we may infect people who are not in the fortunate position that
That's
we
right.
are of being less threatened by this.
Yeah, but the flip side of that is the community is constantly threatening you, right? This is and very asymmetrically. So, yeah. And the other challenge is that the general policies usually don't address the immunocompromised. You just can't make a national or institutional policy because there's a rare fraction of people who are at risk. It's just a problem, right? The question about occupancy limits, there hasn't been any discussion about doing this right now, of going back to density limits. Again, it's because we're in this very tricky position of, yeah, we could do that. We could really go for zero risk, right? We could make everybody stay at home or one person at a time go into a lab, absolutely minimize risk, right? So you get this zero risk fallacy, right? It's actually almost impossible to achieve this, but we could institute lots and lots of policies to try to minimize risk. To what end, right? And for how long? And how does that fit into the larger value that you have as an academic? It's a very hard one to decide what to do on.
Yes. So are there any other questions?
Well, it's good to see y'all.
Crafton for his time and for giving a lot of information. Appreciate
You bet.
that. Sharing.
I think there are a couple more unanswered questions in the chat. Dr. Joseph asked, are there going to be different policies based on class size? And then also addressing the potential for long COVID in vaccinated people. So upon an infection, you know, if we all get a flu-like symptoms for like.
Yeah, so sure, so in terms of class size, the UCOP fall planning recommendations do not distinguish class sizes. And so campuses can modify that. We have not, as far as I know, our campus has not made different policies as a function of class size. But again, these are, we still have a month to go. So everything's constantly changing. In terms of long COVID, again, it's not clear what the true underlying risk of long COVID is. My impression is it's rare to low probability. I like to compare it to chickenpox. So you have chickenpox as a kid. Now you have a lifelong risk of getting a severe case of shingles that could make you blind. They could give you severe pain disorder. We don't change our policies, our medical policies around chickenpox because of the long-term risk of shingles. And so to say that there's a potential remote or long-term consequence of this other illness is inconsistent with what we typically do with medical illnesses. There's all kinds of hypotheticals we can come up with. We can say, well, we should continue to completely lock down because there's going to be another variant that's even worse. Okay, right? You could do that. You could take that choice, but that, again, it's a hypothetical. And so we have to balance hypothetical risks from sort of what we have evidence actually in hand for. And we have pretty good evidence that to date, and I could still be wrong on this, but to date, if you've been vaccinated, if you get a breakthrough case, you're probably going to do fine. Yes.
Are they looking at all at which vaccinations people have received that have gotten this, that have been?
There's been no relationship.
Hmm.
I think that the key thing is probably just time. You know, it's normal after the amount of immune response, about 6 months, by 6 months, you know, you have a lower level of circulating IgG antibodies, and you want that. Otherwise, if you just keep filling your blood up with lifelong antibodies, your blood's going to turn to sludge, right? So you normally just reduce your antibody levels. So that's what we're seeing here in everybody after 6 months. But you're not amnestic to the disease. You have, you know, memory plasma cells in your bone marrow that will recognize the virus. But now you have a race model, right? So this Delta virus comes along and infects you. It's trying to infect you as fast as it can, so to speak. And you now have to spool up a new batch of antibodies using memory cells. And that just takes you time. And so, yeah, you catch COVID, but eventually you make enough antibodies that you don't get severe illness. It's a pretty simple way to think about it, but I think that explains most of what's going on. And it's very different than an unvaccinated person who doesn't have those memory cells, and it takes them even longer to get antibodies generated. So they get very, very sick. So, you know, that's probably all that's happening in most of us.
There's one question. I assume the positive cases within the community have been confirmed by retesting to ensure they weren't false positives, correct? I don't know the answer to that.
Stu would know. You're talking about the students on campus,
right?
I don't know. Yeah, it makes sense. Especially these early index cases.
It's a very good question, and the same holds true for the negative tests, actually, which is why I think 2 of those would be a good idea. I'll follow up with the PIs of these cases if they know, and I'll ask the COVID response team the same question. I think that's a very reasonable question to ask.
I think we're going to see more cases. I bet we're going to get a surge over the next month. It's going to be challenging. There's going to be a lot of scrambling. Hopefully the masks will help, and we'll ride this out without having to take any more drastic actions. Because there's what you're not seeing in the data is how many cases are occurring in Isla Vista and the rest of the county, right? And it's really growing quickly.
Was the question about, are we going back to limiting personnel per room size requirements answered? Maybe that's for the department.
I didn't hear you because you're wearing a mask, sorry.
Oh, yeah. Trying not to get COVID at work.
Yeah.
But was the question, are we going to go back to limiting personnel per room size requirements, even in well-ventilated rooms?
There's no discussion of this that I know of right now. The only step that's been taken so far with this bump in cases is the masking mandate. We really don't want to limit access. You know, you have to remember for the last 6 months, we've had, we being mostly the Office of Research, Joe and Candela, just everybody going, we got to get in the lab, we got to get some work done, right? And so that's this, this is the trade-off we're facing.
It's a tough balancing act.
Yeah.
I have a question about the classroom. Like if you have a lecture hall in Phelps, like Phelps 1160, which is sort of not very open. It doesn't have windows. It has 2 doors leading into a hallway. So it's like, I was wondering the safety of that. It holds like 70 students. And I've already made it so I can split it in half. So we can do 1 in the morning and 1 in the afternoon. So that would reduce the load in that room. But maybe I should have it in the chemistry lab instead in PSBN. Is that safer?
I don't, yeah, I can't comment because I don't know those spaces, but I think, you know, you really have to understand the HVAC on top of the doors and the windows. In general, a classroom with windows on 2 sides with some air blowing through is probably the safest environment you could come up with. There's some good German studies showing that. So yeah, it's so idiosyncratic to the specific room, right? I can't make a general comment on it.
Thanks.
Okay. If there are no more questions, I want to really thank Dr. Grafton for
Sure.
his time and information. We may call on you again. I have the feeling that this is not the last meeting that we're going to have.
No, and there's going to be a faculty senate town hall September 13th, I believe. So I think by then a lot of these issues around classroom are going to get hashed out. So that'll be helpful.
Are there any plans to hold like grad student town halls or like instructional faculty town halls?
It's a great idea. Yeah, there should be.
Right.
Okay. Take care, everybody.
Thank you. Are there any other non-technical kind of questions? We will continue this process of communicating. Let's hope that there isn't that much news to communicate for a while. But like Scott was saying, I am afraid that we haven't seen the end of this.
You know, I have one question. So in the lab, we're trying to encourage students working together, right? With a partner.
Right.
And not socially distancing. So, and then on top of it, there's a learning assistant helping. So now we have 3 people close together. And I'm trying to, I mean, I think actually the KN95 masks, they have the thing around the ear and they work actually. When I went to Austria in May, those were required everywhere. And they're actually really comfortable.
Yeah.
So those, I would like to see the campus require those actually.
Yeah, I think we should look into whether we as a chemist, as a department, can make those requirements. We don't need to wait for the campus on everything, just like we didn't wait on requiring masks in the building. Especially since we're in a special situation where we have labs, not every department has that. And so I'd like us to look into that. I think at least requiring KN95 in labs is a great idea. I had the feeling from the way Dr. Crafton was talking that it was a little bit throwing up your hands because you can't take all the perfect measures, so let's not. And I'd like to be a bit more conservative. I think there are things that we can do in-house that go a little further. So we need to look into this and reach some sort of consensus, but I'm with you. I like that idea.
So I think the other issue to consider is that if you're going to require these, then there's the cost, cost to the students for these masks, and how often do they have to change, and how often do you have to change out the mask and all of that. So just as a consideration when you're discussing this, because I can anticipate students coming and saying that, I don't have money to buy a new mask every day. I don't know. Yeah, there's gotta be something done.
That's a good point too. That's why we need to look into this and think it through a little bit.
I would like to echo Petra's concern about Phelps 1260. I mean, that room is essentially cut off. And there are the two doors, as she's mentioned. One of them, you can leave it open to the corridor, but there are other people trying to do other things in the offices right across the hallway. But it's essentially a closed space. There are no windows or anything of that sort. And it gets, sort of hot and humid even when you're not wearing a mask and not concerned about things of that sort. It's really a very poor classroom space. And if chemistry could somehow find other space that, it provides a good number of seats and things of that sort, but other than that, it's not a good room at all.
Mhm.
I'm worried about fall altogether. I mean, there's this push to go ahead with in-person teaching because that's what we've decided and that's good for the world or whatever. But what happens when this trend goes on, it gets a little worse? You're teaching, the instructor gets tested positive. Are you going to zoom into the classroom? TAs get tested positive. How are we going to manage this? I'm not so
Nobody
sure
knows.
about all this.
Can I ask about the Phelps 1260 room? Do we know, or do we have, I mean, I can look and get this information, but do we have a lot of courses scheduled for fall in that room? Is anybody here teaching in that room for fall? You are, okay. We can look at getting another space possibly. Petra, I can have.
Okay. And usually there's, before me, often CalU is teaching in that room, and after me, often the honors OChem is being taught, or I mean, I see chem people in there.
Okay, we'll look at that.
Yeah. So, but like I said, there was a scheduling issue anyway, so we reserved it at 11 on Friday and at 3. So, but maybe I can find a much smaller space with open windows and doors.
Yeah.
Because I'm going to split those students. But like I said, I'm not sure it's a good idea to have a learning assistant with 2 students in a small space trying to work together. Do you know?
And the TA.
And the TA also. Yeah.
And the shared equipment and the fume hoods.
Yeah, I mean, it's all margin. And surprisingly enough, I got such positive feedback from the general chemistry online year. I mean, we got better and better. At first it was, when we got in spring, last year, I thought, oh my God, 2020, it was really difficult. We're trying to manage, but now I would say it's going really well, and students are learning quite a bit. So, and the TAs have learned how to make it work for everyone. And the TAs are awesome. They're really doing well. So if we need to go back to do one more quarter online, totally fine with me. We're all set to go.
I think there's a plan to possibly ask instructors how they will be delivering their instruction in fall, whether it's a hybrid type of model or if it's going to be fully in person. This is something that we've just talked about getting a meeting together so that we can know what instructors' preference is as well.
Well,
Maybe you can do part of it online and part of it too. I don't know.
but I don't think I want to do in lab and online. No way. Then it's so confusing and so much more work. It would be crazy. So either the labs are going to be online or in person. So.
Right. Someone correct me if I'm wrong, but the way I understand it, right now we're mandated to be in person. There's no option of either or. I don't know what would happen if it's a department, we would say, these are the courses that we would not like to teach in person.
I don't think it was going to be the full course per se, like for a you know, it would be portions of, like, could portions of the lab be online? Like if they give a quiz every lab, can that be done separately than being in person, just to kind of shorten the time that they're spending in the lab? That was what we were talking about, but we'll have that separate from this, so we can meet it. We can talk about that.
Yeah.
Well, there's clearly plenty of concern going forward. The immediate concern is what's happening now, and I'm hoping that we can at least reduce some of the anxiety among our students by giving as much information as we have, which is also not perfect because it's a moving target. We don't know that much.
So Matanya, can I ask, what about other departments on campus, and what's the breakthrough caseload there? I mean, it can't just be chemistry.
And I don't have the answer. From what Dr. Grafton was showing, there is some in other departments. I have to look back at his graphs. He was showing what was happening at UCSB. And it was small numbers, but not only chemistry, I think. But yeah, I can't imagine that we're unique, especially since we're assuming that the infections come from outside of the department.
I mean, I know the marine science graduate program canceled an in-person event because of this also. So they're experiencing it also.
Right. Yeah, there's no way that we're unique. I'm still of the opinion that we should at least do the little thing that we can do, and that is reduce the possibility of spread within chemistry. We can't control the community, but that much we can work on.
So would it
Okay.
be possible to replace the like the signage that's up in the building that says that masks are not mandatory for vaccinated people?
Yes, we were going to change those, or at least we already decided over the weekend that we were going to put up our own signs saying that masks are required, period, irrespective of what those other signs say. And actually Kate was going to look into getting the old signs that have been produced in the past year, of which there still must be hundreds or thousands playing around, to put on there. Definitely. Any other bright ideas, concerns, things for us to think about? If not, it's been exactly an hour. So thank you for hanging around. Any things that you can think of that come up, let me know. I hate to say it, but to be continued.
Thank you.
Everyone be safe, healthy, and well.
Thank you, Matanya.